I would like to thank the Research Network Committee of ESPID for honoring me with the 2019 ESPID Research Presentation Award for oral presentation. I have no conflict of interest to declare. I am happy to present the work that has been done since my presentation at ESPID 2019 and on behalf of my colleagues from Belgium, US, Australia, Switzerland, Netherlands, UK, and Canada. So we aim to explore whether vaccination against pertussis in pregnancy modifies the active immune response to primary and booster infant immunization. And to answer this question, we did a systematic review and meta-analysis. And this is an ongoing project. Last year, I presented some aggregate data meta-analysis using data from 7 articles. Since then, we managed to do individual participant data meta-analysis and add 4 more studies. Today, I will briefly present data from these 11 articles. To answer the main research question, I used a mixed effect model, and the output of this model is the geometric mean ratio. For pregnant women, the geometric mean ratio is the ratio of antibodies in women vaccinated against pertussis in pregnancy versus unvaccinated pregnant women. For infants, the geometric mean ratio is the ratio of antibodies in infants born to women vaccinated against pertussis in pregnancy versus unvaccinated women. A geometric mean ratio of higher than 1 indicates no interference, and geometric mean ratio of less than 1 indicates interference. We first looked at anti-pertussis antibody responses, and here is an example of anti-pertussis toxin. The y-axis indicates the GMR, and the x-axis indicates the different time points. The horizontal line indicates a GMR of 1, meaning equal levels of antibodies in vaccinated versus unvaccinated group. At the time of vaccination in pregnancy, baseline anti-pertussis antibody levels were not different in the 2 groups of women and increased above 1 after vaccination. This persisted at time of delivery and infants before primary immunization. However, infants of vaccinated pregnant women had lower anti-pertussis IgG levels after primary vaccination, before and after booster vaccination, indicating interference. We also looked at other anti-pertussis antibodies, and the same dynamics were observed for antifilamentous hemagglutinin, Fimbria, and Pertactin. And the reduction of anti-pertussis antibodies was in the range of 27 to 58% after primary immunization, 29-65% before booster vaccination, and 24-46% after booster vaccination. The second type of analysis was to try and explore factors that influence antibody immune responses to primary immunization with the focus on modifiable factors. The output of this model was a geometric mean ratio, which indicates the relative increase or fold rise in antibody levels in response to vaccination that is associated with the 1 unit change in a given covariate. For example, relative increase in antibody levels for a 1 week older infant or doubling of antibody levels. And let's take an anti-pertussis toxin as an example. The vertical line indicates a geometric mean ratio of 1, meaning that a unit change in the given covariate does not change the antibody levels after primary immunization. So timing of vaccination pregnancy, age at first vaccination, spacing of primary immunization schedule, or age after primary immunization was not associated with any significant results. The only factor that was associated with blunting or interference was antibody levels at primary immunization. This was also true for antifilamentous hemagglutinin, Pertactin, Fimbria 2 and 3. And I would like to thank all authors of all studies, our colleagues from Vietnam, Belgium, and the data team at the Vaccine Evaluation Center in Vancouver, Canada.